Now, didn't I just say that we get increases in blood pressure and constriction of arteries with adrenergic binding? But there's more sophistication. Didn't I just say that? Now, how would a beta-1 adrenergic receptor cause elevations in heart rate and elevations in blood pressure? How would it do that? It is going to have to produce excitatory postsynaptic potentials on the heart rate structures, on the cells. So I taught you how that happens with the cholinergics, and I'm going to have to show you how that happens with the adrenergics. It is a more sophisticated story, and I'm not going to beat you up with all the details, but I want you to see it. This is how these things work. Now, knowing this, knowing that beta-1 adrenergics bind norepinephrine and elevate heart rate, resulting in increases in blood pressure, what do you think some of the most popular blood pressure medication is in our society? Have you heard their names before? What are they called? Beta blockers. Have y'all not heard this term? Beta blockers. Beta blockers are some of the most popular blood pressure changing medications. There are a lot of people with high blood pressure on beta blockers. A lot of people with uncontrolled issues in heart rate, people who have conduction system issues, and they're talking about putting pacemakers in. They're going to give them medicine to see if they can regulate all this first. The number one choice medicines for regulating heart rate are the beta blockers, the family of drugs that bind to the beta adrenergic receptors in the heart and slow heart rate down by preventing norepinephrine binding to these receptors. The second group here listed are the B2s, the beta-2 adrenergic receptors. And you can see here that the beta-2 adrenergic receptors are found in the airway and the vessels of skeletal muscle and the coronary arteries. This is such an important moment in your lives here in physiology receptor language. How is it possible for one system to turn some things off and turn other things on? There has to be an explanation for that. How are you going to make these cells produce excitatory postsynaptic potentials and these cells inhibitory postsynaptic potentials? The answer is you have to have a different receptor or a different receptor mechanism. You learned one of these already. I told you that acetylcholine causes things to activate in the digestive system, and it causes the heart to deactivate. That can be explained by what you do to the potassium ion channel. In this case, it's far more sophisticated. In this case, if I want the heart to beat stronger, if I want the heart to beat faster, I bind norepinephrine to a particular receptor type called a beta-1. If I want the smooth muscle in the coronary arteries to be inhibited, an IPSP, I have a different receptor there to do that, a beta-2 adrenergic. If I want here, if I want the airway to open so I can breathe, this would be a fight or flight response, right? I need more oxygen to survive. So the smooth muscle in the walls of my airway will dilate. That is a beta-2 adrenergic phenomenon. So an individual has chronic asthma, and they carry an inhaler with them. And sometimes they have an attack, an asthma attack, and they take the inhaler out and they breathe drug into their respiratory system. What do you think that drug is?
Is it a type of steroid?
Okay, there are steroids in those drugs. That's true. Okay, I haven't talked about alpha yet, so I wouldn't be doing that to you. What is this? This is a norepinephrine drug, right? The drug itself is going to be designed to bind to what kind of receptors? Beta 2s. Do y'all see that? These drugs are adrenergic agonists. They bind to the adrenergic receptors. Now, what's going to happen to an individual's blood pressure who breathes a drug in that is a beta adrenergic agonist? Why is that? That's right, Danny. Okay? Because it will cause some constriction of vessels, and what else will it do? It's going to cause the heart rate to go up. So the drug doesn't know, right, whether it should bind to a beta 2 or a beta 1. So there are different groups of these drugs, and the pharmaceutical industry sells them based on their specificities. So if you want the cheap stuff, which most asthma patients, young people at least, would have, you want the cheap stuff, you're going to have an adrenergic agonist that is indiscriminate. It will bind to the beta 1s or 2s. But obviously, if these receptors are proteins, they have different binding sites. And we know now where these drugs bind. That's the whole thing with the pharmaceutical industry, to develop drugs with specific binding sites to specific receptors. So if you want the expensive stuff, what do you want? I don't want the drug. I want the drug to open my airway, but I do not want the drug to cause changes in heart rate. What do you want? I want a drug that binds only to the B2 receptor. Exactly. So these are available. And so if an individual has hypertension, you're not going to give them a beta agonist. You're going to give them a beta 2 agonist so that you don't impact their blood pressure. Okay. All right. Now, the rest of this will come as we go in the semester. Kidney regulation, reproductive regulation, widespread vessel things. The pupil stuff will come up in the next test section, and we will address each of these, okay? But I always use the first two to get the students started on their journey in adrenergics. And now I want to teach you how they work, okay? So this picture shows you the end of a neuron here, and you can see tyrosine in this image. This is an important observation. Note that tyrosine is first in the list, and you should also be able to pick out dopamine and norepinephrine in this list. These are what we refer to as the monoamines, and some textbooks will call this grouping, because of where the OH group goes, the catecholamines. These are the monoamines being produced from tyrosine. Dopamine and norepinephrine are both in this list. Now, in this particular neuron, you can see that norepinephrine is produced and released into the synaptic cleft. Now, once norepinephrine is released, it's going to bind to its receptor. For what you know from me, the receptor over here, the postsynaptic membrane, could be a beta 1 receptor, in which case it would cause an EPSP. I'm going to need a little bit more. Or it could be a beta 2, in which case it could cause an IPSP. Now, after the neurotransmitter has bound, we have to do something with it. And this always happens. The stuff either diffuses out, or what's more likely is the neurotransmitter is going to be destroyed either by a postsynaptic enzyme, which acetylcholinesterase was, or something on the presynaptic side. Okay, so here's another important moment in your neuropharmacology introduction. Norepinephrine and the other monoamines have enzymes in the postsynaptic membranes that destroy them. The general reference to those enzymes is COMT, catechol O-methyltransferase. That's not important. The name is not important. These are COMT enzymes that destroy the chemical on the postsynaptic membrane. Stop it from doing its work. So if you wanted, as a pharmaceutical individual company research, you wanted to do something to stop the norepinephrine signal or to increase the norepinephrine signal, you could do things that modify COMT. That, however, has turned out not to be the better strategy in neuropharmacology to adjust neurotransmitter levels. In fact, the much more likely, the much more prevalent drug availability is on the other side, and you haven't been introduced to this one. As it turns out, for all of the monoamines, there are also reuptake mechanisms, proteins on the presynaptic side that act like buckets. And they're specific buckets. They're looking for particular molecules. And they reach their arms out into the synapse and they scoop up particular neurotransmitters, monoamines. And each of these buckets that's used to scoop those neurotransmitters out of the synapse are specific. They go after individual neurotransmitters. That was the finding for depression medications. The proteins in the presynaptic membrane that pull the neurotransmitter out of the synapse have specificity. There's one for norepinephrine. There's one for epinephrine. There's one for dopamine. There's one for serotonin. And now we know there are different versions of these. So there are reuptake proteins that scoop specific neurotransmitters out of the synapse into the presynaptic side. Once they are here on the presynaptic side, they are destroyed indiscriminately by an enzyme. It doesn't care. Anything made from tyrosine. This enzyme is called monoamine oxidase, MAO, and it is the destruction enzyme presynaptically for all the monoamines. Now, I'm using some language today that should sound somewhat familiar to some of you. So the next time you see a drug commercial, listen for stuff like this. This is one of the most common things mentioned in these drugs that treat depression and anxiety disorders. These drugs called MAOIs, monoamine oxidase inhibitors. Drugs that prevent the destruction of the monoamines, which would facilitate the re-release of those into the synapse. Monoamine oxidase inhibitors are, without dispute, the most powerful antidepressant medications. Without dispute, the most powerful. But they are not the most used antidepressant medications. And I'm wondering, as a fledgling neuropharm learner, if you cannot already see why that is. From what you've learned at this point about the monoamines, we know that the MAOIs are the most powerful. They prevent this enzyme from cutting up the monoamines, which causes massive release of these chemicals into the synapse. And we know that's very effective drug treatment for depression. Why not use it for everyone? Why do clinicians prefer not to prescribe the MAOIs? I haven't even talked about serotonin yet, but you should see this now. What's going to happen to the levels of norepinephrine in the synapses all over my body as I inhibit this enzyme? What? It's going to increase. And increases in norepinephrine, increases in synaptic norepinephrine will have very specific effects and impacts in the human body. Can you think of some of the side effects of an MAOI? What, for example, would you expect an MAOI to do in the digestive system? What's that? Slow it down. So impairment in digestion, right? Slowing down peristalsis and the release of gastric juice, the release of pancreatic enzymes. Very common for digestive problems to accompany this because of the role of norepinephrine. What else? Yeah. So what's going to happen if your patient is hypertensive? If you give them an MAOI? Right. Heart rate's going to happen to go do what? It's going up. Right. So what's going to happen to blood pressure? Yeah, so this is one surefire way to cause a stroke. Give somebody an MAOI who's hypertensive to deal with depression, and then they have a stroke, and now you've lost a patient. You've completely destroyed someone's life by doing that. So the answers to these fundamental pharmacology questions that are happening very frequently in our society today are found in this core fundamental knowledge about what the neurotransmitters do. Okay, so this is the mechanism for norepinephrine. Now, there's a lot typed here, and I don't expect you to know this. This is for the upper level kids, all right? But I want you to see over here something that I'm going to use to teach you a fundamental principle that you can use for the rest of your farm experiences. Whenever you explain what a drug does, then this is what you're going to use. All right, so you can see here in the first step that norepinephrine binds to a receptor. We would call this a chemically gated ion channel or a chemically gated receptor. It fits in that category. But just like the muscarinics, it is not in fact a channel. You can see that the impact is ultimately going to be on an ion channel, just like the muscarinics. But there is a sophisticated series of things that happen inside the cell to determine whether or not the binding of norepinephrine to this particular receptor will either be excitatory or inhibitory. And I'm not going to beat you up with that. Don't think you're getting away with something, though. Because in the spring, you're going to learn the cyclic AMP pathway, and you're going to see this again. I'm going to do it in the adrenal gland, but the second time through, I will have taught you hormone mechanism, and it'll make more sense. Okay, for today, I want you to see that the receptor is linked to an ion channel, and a good anatomy and physiology student already knows what ion channels neurons and muscles are interested in. What are they? Sodium, potassium, calcium, and chloride. Okay, so now you tell me, if the impact of the adrenergic binding is on a sodium ion channel and it opens, will that adrenergic binding be excitatory or inhibitory? Excitatory, because sodium goes into the cell. If that ion channel is a potassium ion channel and it opens, then the effect will be inhibitory. If that ion channel is a calcium ion channel, calcium is also more concentrated outside the cell, and it carries a plus charge. So calcium entry causes excitation. If this channel is a chloride ion channel, and I'm going to bring this one up one more time, a chloride ion channel, then what will the effect be? Chloride has a negative charge, and it also is more concentrated outside the cell. So it comes in, the cell becomes more negative. So it will depend for each one of these adrenergic receptors on a number of other issues as to whether you will open or close and what kind of ion channel this will be. But if you know the fundamentals, you will be able to understand any of them. And the fundamentals are sodium, potassium, calcium, and chloride ions. These will explain most of the impacts of drugs associated with adrenergic binding, the impact on those electrolytes. Okay, now let's talk about serotonin to finish today. I brought it up already. This is the other neurotransmitter, serotonin. It is related in structure to norepinephrine, epinephrine, and dopamine. But serotonin, as it turns out, is made from a different amino acid. Serotonin is made from the amino acid tryptophan, whereas norepinephrine, epinephrine, and dopamine are made from tyrosine. But it is a monoamine, and it's located here in the presentation in order to keep you thinking about the depression drugs. And so I've got them listed here. The most popular ones prescribed are Prozac, Paxil, Zoloft, and Luvox. And these are all drugs that deal with the serotonin system. So first on the list, these neurons are associated with cell bodies in the raphe nucleus. Serotonin neurons in the raphe. This is a very important brain region, the raphe nucleus. I've not talked about it with you, but I would like for you to know where this stuff is coming from. Where is all this serotonin coming from? Because when I get to dopamine, I'm going to show you where it comes from as well. Okay, so serotonin is made in the raphe nucleus. We know that it is involved in mood, behavior, appetite, and cerebral circulation. All important things that serotonin is involved with. The drugs that impact the serotonin levels that are the most popular today are called the selective serotonin reuptake inhibitors. Now, let's go back here. MAOIs are the most powerful, but they're not used because you can kill people with them who have cardiovascular issues. This is why the SSRI medications are more popular, because we know that serotonin also has an impact on mood. And so these drugs are designed to inhibit these specific proteins that are scooping serotonin out of the synapse. They are selective serotonin reuptake inhibitors. They prevent the mass reuptake of serotonin, leaving serotonin in the synapses. And these have side effects. But the side effects of these are much more manageable than the side effects of the monoamine oxidase inhibitors. The beauty of this for the pharmaceutical industry is, of course, that the discovery of the selective reuptake proteins has resulted in billions upon billions of dollars. Some of you would be surprised, some of you would not be. If we could put as many of you as there are in here, primary care physicians in this room, and we did a survey and we asked them, what is the number one reason for visits to your office? This is what they would say. Depression. What is the number one drug of choice that you're going to use to try to help individuals who are clinically diagnosed in your clinic? And the answer is the selective serotonin reuptake inhibitors. Whether you're talking about some kind of anxiety that induces depression disorder or some other kind of depression, very, very difficult to diagnose. You cannot take a blood sample and tell someone you've got low serotonin, so you must be depressed. That doesn't work. You can't stick probes in people's brains and determine that serotonin levels are lower or higher. People don't take well to that. But the impact of the SSRIs is undeniable in today's society. And so they are, the use of these drugs as antidepressants will always fit in every annual report of the prescription drug list. It will always fit in the top 5 and normally the top 3 for prescriptions in the United States, sometimes number 1. So these inhibit the reuptake and destruction of serotonin, prolonging its action. And today, my intention was to teach you the basic fundamentals of why these things work the way they do and what the chemicals are related to them. Now, the last one I'm going to do in detail is this one, and then there will be a smattering at the end of others. The last one, the detail I'm going to do is dopamine.